All guidelines endorse that AEC over difficult, in cases of difficult intubation, is having a very good chance in re-intubating such patients. These are the other conduits which we can use. As I said, you can keep this AEC for a period of 2 hours to 2 days, and if doubt, you can insert ETT over AEC if needed. If you are anytime you think that the patient will not be intubated, not be extubated that early, you can just re-intubate such patients. Now we have a scenario 4 where we expect the patient has an airway collapse. Because of surgical intervention may make airway difficult or complex. So long-standing neck surgeries or mediastinal surgeries, thyroid swellings, airway procedures prolong such surgeries, and Trendelenburg position could also cause some sort of airway collapse or airway edema. So in these cases, we always either supports or goes for a leak test to assess whether the airway edema or collapsibility will be there, and it is always a quantitative test, and we assess the volume of the leak which is there. So it is around 110 to 130 ml of air, or 10 to 25%. If it is more than that, naturally we think that the patient can be extubated over an AEC. If the leak test is absent or unequivocal, then you may delay the extubation, or extubation can be done over an AEC in a controlled environment. And if you have suspicion of airway collapse still persist, that if you think that the airway collapse can still persist, extubation can be done in OT under sleep, deep inhalation and anesthesia in spontaneously breathing patient. That is one option which is always there. And if obstruction persists, then obviously you have to re-intubate this patient and go for a tracheostomy. So what are the post-procedural plans which you should do when you extubate a patient? The most important thing is that the patient should have oxygen supplementation continuously, observe for airway compromise if controlled and monitored environment should be there, and document difficulties. Most important thing is documentation is very important when we are discharging these patients, strategies and adverse events, what has happened to these patients. And counseling such patients is again very important for us. So to summarize, extubation is a planned procedure. Continuous assessment and controlled environment is always a must, and equipment and expert help is always a must. These are the things which you should always have, and you should be happy that the patient is in a controlled environment. The strategic stepwise approach, again, as we said, is very important in dealing with such type of patients where you anticipate or predict that the patient will have a difficult extubation. Means after the patient has a difficult to intubate, naturally the patient can land up with a difficult extubation. So you've got to have a strategic stepwise approach in such patients. Use of conduit, this is very important, which most of the time we are not using it, but we should use it wherever you are in doubt. And supraglottic airway device exchange is an advanced procedure, so you must have an expertise over it. Our expertise people should be always there, experienced and expertise people. Leak test is something which you always forget to do it, and I think it is at times very handy, especially in situations where we expect an edema or a collapse. We can take care of by doing a leak test, and then appropriately try to let the edema subside or collapse be decreased, and then you can extubate such patients. Oxygenation, all the previous authors, they have already always highlighted this. This should be perioperative. I mean, what I mean to say is preoperatively, intraoperatively, and at the time of extubation. You should always, post-operatively, you should always think of oxygenation. This is very important for us. And you should know the methods, how you can oxygenate such patients, and at what flow of oxygen and what type of techniques you should adapt. So elective tracheostomy is a safer option in certain situations. As I said, when you know that the patients are not going to come up, and you think the patient is moribund patient, is skeptic patient, patients are old age patients not being able to cope up with surgeries, you can always go for a upfront tracheostomy in such patients. And if you don't have facilities to really come back for an re-intubation situations, you can always go for an extubation, an tracheostomy in the upfront. At the end, I must thank the organizers again, and I'm really thankful to the editor IJ for permitting me to go ahead with the algorithm, the IDA officers, Amit, and Dr. Amit and Apex. Thank you so much.
Thank you, Dr. Mohit. I think we've come to the end of the session, and if there are any questions for Dr. Mohit or other speakers, they can come forward with. You can come forward. One situation that I would like to ask Dr. Mohit is, of course, not in the OT but in the ICU, is unplanned self-extubation that one has to deal with. And in those scenarios, what are the things?
Actually, very nicely said, but this was primarily based on operation theatre. Again, I will deal that situation again. See, unplanned self-extubation is primarily because of the patients not being managed on a ventilator. Usually what happens, the patient is not being adequately sedated, and the patient is fighting on the tube, and suddenly one fine morning you find the patient has self-extubated. Now this is something which we should be always careful. That means our planning has not been appropriate when to extubate, and we have not gone for the protocol ICU management on sedation. This is one very important thing which we always are not doing outrightly in most of the situations, and that there is a fault. Actually, it is not the fault of the patient or the person.
It's the fault of the therapist.
It's the system failure primarily.
But the outcomes are inferior.
If such patients really get extubated, then obviously if the patient was already having a difficult intubation at the time of extubation, then probably it lands up in a situation, especially at night when there is no experienced anesthetist with you. You should have certain devices. Nowadays we have started keeping certain devices which helps you in these situations. You can go with your supraglottic airway devices, or you can go with your video laryngoscopes, which can help you in these situations for intubation. But if you don't have it, obviously you have laryngoscope which is there, the best person, but always go for an help. Never think that you will be able to manage such patients. This is the most important thing. We always forget of asking for an help. Help is one thing which we should always take care of and should always call for, and if needed, they are really something which we always forget.
Thank you. Any questions from the audience?
Can I ask one?
Yeah, sure.
I am Rashid, and my question is directed not to you, Mohit. Dr. Savita, can I just want a little opinion from you? When you have one of these patients who are badly facial smash, there is a concept now which is called as double setup, where you take one single attempt at laryngoscopy by the senior most person, and if he fails, then immediately the person who is expert in cryo or tracheostomy, he is standing by the side, he takes over. So there is no concept of going for, say, a laryngeal mask airway or any other thing between one attempt and the tracheostomy. What do you have any experience on that?
Do we have a mic?
No, in A&E area, because these patients, they hardly will come to the OT in a...
People are doing just like that. Hello. In our casualty also, when the primary care provider who are there in the casualty, they are doing the same. The person to provide endotracheal intubation is also there, and the other person is also there. But they are not senior most person, you know. They are the SRs or the, say, final year postgraduate student who would perform. And if it seems unlikely that it is going to be successful, immediately the surgical colleague take over and they perform the front of neck.
So the thing is that actually the senior most around that place, he should take one single attempt only.
Yeah.
No other person should say, okay,
ideally, let me... Those senior most who is around, that is the person doing.
Here we come across a case. I am Dr. Gopal Reddy, Telangana. We come across a tight vocal cords, not admitting even the bougie also.
Sorry?
So, not admitting the bougie also, tight vocal cords. And because with 50 saturation, we took that patient to the operation theatre.
No, why did the patient have a tight vocal cord? Means the patient is in laryngospasm?
No, it's not laryngospasm. He's having some pathology with vocal cords.
That means the patient was already anticipated difficult intubation. Tight vocal cord means the patient was not being able to breathe properly?
Not able to breathe properly. And is also, vocal cords are not at all moving, even after this one also.
What I mean to say, not at all moving, it's in the midline. It's opposed.
No.
Sir, your question is addressed to which speaker? which your question is addressed to?
It's referred from this one.
For extubation or for intubation or for trauma?
It's referred from this one, this one.
Trauma.
Pulmonology department, because saturation is not maintained.
Now you want to ask this as a point of extubation or as a point of
intubation. Even we are unable to admit this
Dr.
one.
Moitra,
Bhuji also.
You can come.
In that case, ENT surgeon was by the side. We have to do the tracheostomy, then maintain like that only.
No, that's obvious. Patient is vocal cords are tight fitting. If the patient does not have a laryngospasm, if it was a laryngospasm, then the management would have been different.
No, it's only vocal cord pathology. It's only vocal cord pathology due to that one, fixed vocal cords.
Then obviously the upfront should be that if you are not being able to open the vocal cord, the most important thing is you go for cryo. That is the only thing, surgical cryo.
And second case, some mass was there below the larynx, not diagnosed by our senior residents. And after giving anesthesia, again, they were unable to intubate. They are seeing the vocal cords, but mass is below the vocal cords. In that side also, mass ventilation done, and ENT surgeons, they done this one.
Now the patient, they had a mass there in the vocal cord.
Below the vocal cord.
Below the vocal cord.
Subglottic mass.
And subglottic.
Subglottic, big mass. They were not diagnosed. Even the ENT surgeons not diagnosed. And also our people also not interested.
You did not have any CT scan,
no. That was not done.
Forget CT scan. A good history it must have been taken. A big mass subglottic will definitely give some symptoms.
The patient must be having a history also of distress.
Mild distress is there. But ENT surgeons, they taken that case, granted, they can do some surgery for that man and already placed in this one. They brought that case to me. Again. So sometimes this subglottic mass also give us a difficulty. We have to think of those things.
Yes.
Below this one upper.
Thank you very much, sir. We have one more gentleman.
Must be symptomatic in that case.
Excuse me. You come back. Come.
Patient must be symptomatic in these situations. I think
he's waiting for very long for a question.
Thank you, sir, madam, for giving me. But I need first permission from your side, because my question is indirectly to madam, but directly to Sir Rashid, if you permit. Actually, I want to not it's not question.
Sure,
it is a clarification basically as a
please go ahead.
anesthesia.
Yeah, ask your question.
Sir has said that double setup is required and the senior most person should attempt. Suppose I am the consultant there and I have senior resident, I have PG and I am working for last 3-4 years. I hardly intubate once or twice in a difficult situation only in a month or twice to a month. Am I the right person to be the senior most to take the call for the first intubation, or the senior resident who does every day 2 intubations per month? He is the right person. So I just wanted.
This was a very good debate. I mean, there were a lot of studies which have
maybe Dr. Moitra wants to answer this question, please.
Your question is giving the answer.
Actually,
can you give a mic to her? Can you give a mic to her?
Yeah. Yes. Experience.
Better. And you know the skills of the people around you, right? So you're absolutely right. It's a person who would be more skilled and not necessarily the senior most person, but someone who's very experienced, even if he's not intubating every day, might be able to save the situation better with the decision making and the planning. So it's really a team effort, and you know who to hand over to.
Most importantly, because of the anticipation, you can anticipate as an experienced person what is going to happen in such situations.
Right. So you can't really define that it should be the senior most person. So it's the person who is more skilled to handle that situation in that clinical context.
Thank you.
Thank you.
Your question is answered, right?
I am Dr. Sanjay. A simple question is, suppose while intubation, if there is an esophageal intubation, are we supposed to change the tube, or in hurry? Usually what we do, we put the same tube for intubation in a repeated attempt rather than changing the tube which has gone into esophagus.
So I think you can do both. At times what happens, since if it depends upon the visibility of your, of your larynx. See, if you are not being, because this situation is something which you are not being able to probably visualize your larynx. So if you are not being able to visualize your larynx, then obviously you can take a fresh tube. You can best is you pass a bougie and then through that you railroad. This is what's important. But if you think the epiglottis is visible, and I mean larynx is totally visible, why do we need to put the tube there and then take another tube? So you can take out the tube and intubate it depending upon what next step, what should be your changes while you're intubating the next time. Whether you need and still it, or whether you need and some other equipment, or whether you need some other experienced person. Depending on that.
My question was, sir, suppose I have done an esophageal intubation wrongly. It has contaminated.
Yeah.
Now the same tube can I put in intubation, or should I change the tube?
Yeah.
Please go on.
Change.
Contamination. Infections, and you're talking about contamination. But again, it depends on the context, and you know that's not what usually happens. You land up putting the same tube in a hurry. But if it's something that's what you prefer to do, it's a good idea to change the tube if you can do that. But again, remember, not intubating will not kill the patient, not oxygenating and not ventilating will. So if you plan to do that, a lot of people, even if they are in a position to change the tube, don't do that because they think there's a hurry to intubate. I think there is a hurry to ventilate and oxygenate this patient. So if you want to change the tube, go ahead, ventilate this patient, bring up the saturation and change the tube. But yes, ideally, you should change the tube because it's already contaminated. So if it's possible to, you must
potentially contaminated, but not necessarily, and the patient flora is the same. And more important thing is that the scenario is such a emergent scenario that you may not think about. If there are people helping you and the tube ready, then you can do it, but not think about this.
Most importantly, taking another tube or bringing another tube that could be, I mean, you can waste time.
This should not be
so
what
that is important.
It should be on your mind at that time. It should be to intubate the patient and ventilate the patient.
Yeah. Ideally, you should always have a fresh tube, but if it is not available, you are wasting your time to get another tube and then you go for an intubation. So when one tube is in front of you, you can go ahead with, because time and patient is more important there.
Thank you.
Thank you.
Sir, immediately after extubation, there is hypoxia and you want to re-intubate. Can I use choline at what interval? What time I should wait?
Sorry, what was it? You extubated the patient and then...
I have given reversal and extubated.
Uh-huh.
There is desaturation.
Right.
I want to re-intubate the
First
patient.
you oxygenate the patient.
Okay.
Right? Ventilate the patient, oxygenate the patient, bring up the saturation. Most importantly, you've got to bring up the saturation. That is most important. You've got to oxygenate. Unless that is not possible.
His question is, can we give
I got my one. I'm just answering that. Question is, first is oxygenation. If you're not being able to bring up the saturation, you must know what is the cause. And if it is because of laryngospasm, you can go for a jet ventilation, I mean an emergency high flow oxygenation that can release your laryngospasm. If not, you have to go for low dose sucks.
My question is,
you can go for sucks.
Sir, what is the interval for the fear of dual block where we can give choline after reversal?
I'm not sure about what is there. You can give immediately. There's no questions on that. What is the phase of
dual block will occur after repeated dosages and a lot of
for that.
I don't think you need to wait for, think about dual block at that point of time, because you need to relax and intubate the patient. So dual block hone se bhi aap relax kar doge. If you are relaxing the patient, at least you intubate, and that dual block can be taken care of later on.
All these things can be dealt with.
And usually very low dose of choline
is patient is desaturation, you don't think about dual block. You think about relaxing the patient, intubate. That dual block you ventilate the patient as long as the dual block is there and to overcome that problem. Yeah, that's what I said. Depends upon what is the cause.
Give propofol.
Oxygenate and propofol is always there if you can go ahead.
Oxygenation is okay, but don't use sucks at the first line of trying to relieve this.
But he has given a scenario where he is wanting to use sucks.
No,
that's what I'm saying.
He has to be told that it will be better if he avoids and he goes to propofol, say 2 or 3 ml.
Okay, may I make one point?
Yeah.
Yes.
No, that is one thing I said. You can increase your flow, go for a high flow, and then that can also, take care of your laryngospasm.
I think we'll bring it to a close with this point. His question is dual block. And today, dual block relevance is not much when you are ventilating patient for hours and days. So don't worry.
Don't worry. The point is you need to relax and intubate the patient.
Actually, he didn't mean dual block. He just wanted to know how much dose should I give. Can we give?
Low dose.
That is the only problem. Dual block.
Low dose and you need to relax.
Accidentally, I think.
The idea is that hypoxia takes precedence over every other consideration.
Yes,
exactly. If you have a living patient, you can address dual block and every other contamination and all those things, if the patient is alive. So hypoxia has to be treated first.
Yes.
Hi, I'm Dr. Divya from PGI Chandigarh. My question is directed towards Dr. Sheila. Madam, you just highlighted the coming up of the universal guidelines. So the IDA guidelines actually came up just so that they could be better suited for our clinical settings. Having a guidelines which was, so this is like we're going back to the same problem, having a universal thing.
Right.
Again,
No,
which
just
might
to
not be suitable for all settings probably.
Right. Now, IDA guidelines happen to be made in India, but we didn't keep it in mind only for India. It was basically, we looked at it as a guideline that would be robust, that would look at all the evidence that was available, and to make a good guideline that could be used. It was not only for the Indian setting, but what I'm trying to say is, I would say it's more universal because it tackles every setting. It's not only India. I might be looking at Africa. I might be looking at South America. So it's something that encompasses all situations. So if you look at the international guidelines, they look at scenarios where everything is available, whereas our guideline is actually more global because we've given even options like do a tracheostomy in a situation where you don't have...
Absolutely. Actually, management is more about what things you have and managing things accordingly.
Right.
So rather than
segregating
and making it more tailor-made.
It's not about making it tailor-made. Again, that's why I gave the definition of guidelines. One should understand that guidelines is to promote good clinical practice. So someone says in a district there is no flow meter and there is no, things like that. It is so that the person in the district says, yes, now I need to do this. Yes, now I need to move to the standard. So really guidelines have to be at a particular level so that people can reach that level. It is not to, continue with the same practice that's going on at a small district hospital. And this is a continuous argument that's always there. Oh, this is not there, that is not there, and you all are in institutes. No, that's the wrong thinking. It's when you see the guidelines that you say that, oh, our hospital doesn't have a pulse oximeter, so we should make a pulse oximeter available. So in that sense, I would say the IDLA guidelines are really quite global because they fit all the clinical contexts in different parts of the country, globally,
I think we've had a stimulating session and a lot of question answers. I think we'll wind up at that.
Sir, can I take just some more seconds, if you allow me?
Sorry? Okay, please. A quick question.
I have just a brief query. Sir was saying that we can keep AEC for 2 hours.
Yeah.
Sir,
2 hours to 2 days.
Do you think the patient will be able to tolerate it for 2 hours, or it will aggravate the airway edema also?
Surely you need to deepen the patient. That is there. Got to deepen the patient. You can, if you think that the patient's edema is not subsiding, and you now need to keep that tube, the patient's collapse is still there, you have to keep the AEC there. And if you think that the patient need to be intubated for a prolonged period of time, you can automatically re-intubate the patient till that edema and collapse is taken care of.
So don't you think that it will aggravate the airway edema also itself?
No, why? You are subsequently administrating drugs to reduce that edema. You are administrating drugs to reduce that edema. You are giving steroids, you are giving, in fact, sprays. So that is also decreasing your edema.
Okay, Dr. Mohitra, last quick party.
Staged extubation catheters. So you don't really need to keep the catheter, you have guide wires, So these are better tolerated and you can rewire the kind of catheter over this guide wire. So there are many newer sets that are available it's just that people are not familiar with it, but there are newer things that are better tolerated by the patient, which you could use. But the important thing is to use a tube exchanger, to use something like this during extubation. A lot of times we just extubate the patient and we don't, when we have a problem and we, then burn our fingers. Remember, extubation is always elective. Yes. Unlike in an unanticipated difficult airway, there's no hurry to extubate. If you're not sure, if you don't have the equipment, you can always call an expert. It's always an elective procedure. So in an elective procedure, to burn your fingers with a complication is really, really a tragedy. And exchange catheter is something we really need to use more frequently Whereas people very confidently extubate and then have situations where they, lead into to trouble situations.
Thank you, Dr. Mohitra.
Thank you.
And with that, we come to end of this session, and I would like to thank all the speakers. It's been a very nice interactive session, and I would like to thank the organizers for this program. Thank you.
Now I request Dr. Prithvesh Bhattacharya to felicitate Dr. Saeed Moed with a token as a plant. I request Dr. Dipul K. Bora to felicitate Dr. Savita Seni with a plant. Next session, 5 minutes, start 11 seconds. Start. So, with the completion of such a wonderful session on airway, we are starting with the second session as a plenary session, and I am inviting my chairperson, Dr. T.C. Pipple, sir. He is head of the department anesthesiology in the SN Medical College. Sir, kindly take a seat. And second chairperson, Dr. Ajit Gupta. He is professor and head, Department of Anesthesiology, Critical Care, Indira Gandhi Institute of Medical Sciences, Patna. Sir, I request Dr. Ajit Gupta, sir. What is the time? I again request if Dr. Ajit Gupta sir is here in the hall, please take a seat on the dais. Oh God. क्या टाइम हो गया सर? 11:20? नहीं 11 बज रहा होगा. तो जस्ट आफ्टर 5 मिनट्स आप नेक्स्ट स्पीकर को बुला लीजिए, क्योंकि हम और एक और बैठ के मैं फ़ोन कराती हूँ. खाए बगैर
Hello, hello, hello.
No, it's just not working. So I had one department, a private hospital.
Now let me start the second session of this day. Now invite Dr. Andrew Klein. He will speak on the research fraud, who, how and why. He is the consultant working at the Royal Papworth Hospital, University of Cambridge. His major achievements are Editor-in-Chief in Anesthesia, Board of Directors, Association of Anesthetists, Executive Boards, National Institute of Academic Anesthesia, Research and Grants Committee, College of Anesthetists of Australia and New Zealand, Committee, Association of Cardiothoracic Anesthetists. Now welcome Dr. Andrew Klein. Please.
It's still early. 5 minutes.
Yeah.
Yeah, do you want to start?
Yeah, you can start.
Let's wait.
Should we wait?
We'll wait.
Yeah.
We have got 5 minutes.
Because I think people are still getting coffee.
Okay.
How are you? Nice to meet you.
Nice.
Hi. How are you?
Yeah, nice.
Nice to meet you.
There's some difference in watches.
Oh. So
3 moments.
Okay.
I'm inviting to our third chairperson, Dr. Vasundhara Atre. He is anesthetist. He's working in cardiothoracic and many other fields. Ma'am, please take a seat. And in 1 or 2 minutes, we are starting with our first speaker, Dr. Andrew Klein.
Everybody's having a tea break.
Yeah, they have. Yeah, still from our time it's 5 minutes.
Before time. आपका है डॉक्टर साहब?
I'm Dr. Ajit Gupta, Professor and Head at Anesthesiology and Critical at Indira Gandhi Institute of Medical Sciences. It is a central university, just like AIMS. You have?
Dr. Saab, I'm now in the admin space actually.
Okay.
But 15 years of cardiac and 5 years of liver transplant. Now I'm heading the Neti group. Neti hospitals.
Although I'm a professor head, but most of the work is my administrative.
I know that is what it happens after a certain seniority.
Yeah, later on. So I'm looking after so many areas, but concentration is on emergency life support and training the young doctors, NGOs,
correct,
firefighters, police, all for emergency life supports.
I must call you to the hospital for a session with my team.
Yeah, sure. Yeah. Just asking. Have they reduced the timing for conducting? 30 plus 5. Yeah, all together it is 35. 25 and 10, I think. They have not made it clear.
Thank you very much. Can I have the first slide on? Thank you very much. Welcome, good morning to you all. Thank you very much for the invitation to come to AGRA. I'm going to talk to you about research fraud. So this is a scary subject. This is a subject you never really want to know about, but this has been in the news a lot. So you'd have read it in the newspapers and online. So I'm just going to talk to you a little bit about what's been in the news and what you could have heard about. So my name is Andrew Klein. I'm an anaesthetist from the UK, from Cambridge, University of Cambridge, and I'm also the editor-in-chief of Anesthesia. So I spend about half of my life reviewing papers and assessing data, and unfortunately, we do get some fraudulent articles. So I'm going to tell you a little bit about how we spot them and what we do about them. And I just want to acknowledge the help of these very clever people who have helped us with this work. So John Carlisle, who's one of our editors from England, Steve Schaefer from America, Steve Yentis also from England, and then some Australian authors as well. So the learning objectives from today's talk is the different types of scientific misconduct. So what people do that's bad and what it is, and why they get in trouble. So how you can spot fraudsters, how you can spot people who are doing bad things, and how we catch them and what happens to them. So this is our journal, Anesthesia. This is my job. I'm the editor-in-chief. We have an impact factor of 5.4, and we have a lot of Indian authors that submit papers to us and a lot of readers from India. So we welcome any Indian authors, doctors, researchers, postgraduates to read the journal and to submit us their work. And if you want to subscribe to the journal, you can join the Association of Anaesthetists. There's a special offer where you can join outside for 3,000 rupees to get the journal on your iPad or your phone or your computer. So you can join, you can read the journal, and you can submit your articles. And you can follow us on Twitter. So Twitter is a very big way. All the articles we tweet about are for free, and you can read them on your phone or your iPad. Okay, so I'm going to start talking about fraud. This is the most common type of fraud, which is plagiarism. So this starts at school. It carries on at university, and people do it as doctors, as postgraduates, and consultants. This is basically copy and pasting somebody else's work and putting it in your own paper. So we run every paper that's submitted to the journal through plagiarism software, and we know how much you've copied from someone else. So 5 to 10%, of course, is a little bit similar to other people's, but anything over 30%, and we will reject your paper. And every day we get papers where people have copied other people's work. So this is actually fraud, because you're using somebody else's work that's already been published and that has copyright attached to it, and you're trying to pass it off as your own. So this is illegal. It's against the law. It breaks copyright law. And if you do it, and you're at university, you can lose your degree. If you do it as a doctor, you can lose your job. And we automatically run every article through plagiarism software. So we know every article, every thesis, every doctorate, anything that's ever been published anywhere in the world, we can find out if it's being copied. So we will run it and we will find it. And every day we find somebody that's trying to do this. And now they do this at university for people's medical school exams, for their degrees, and so on and so forth. So this is the most common type of fraudulent behavior. So some people will actually submit their article to many journals at the same time. And we find out, this is called duplicate publication, where one journal publishes it, and then 6 months another journal publishes it, and 6 months another one. So that's called duplicate publication, and that's also illegal. So you can only submit your article to one journal, and you have to wait till it's rejected or accepted. Once it's rejected, then you can send to another journal. So duplicate publication is also quite common, people trying to get the same article published 2 or 3 times. Another thing this is common is where people use the same figure in an article and then in another article in another one. That's also illegal. You can't use the same figure or the same image. So for example, this was an image in a cancer journal, and I know my colleague Ravi is talking about cancer next, and they published some PCR data, so qualitative PCR from various enzyme pathways, and they published that in 4 different journals, the same picture, the same PCR picture. So all 4 articles were retracted. So you can't use the same image, the same figure, more than once. And then this is the most recent type of fraud, where people fake their data. So this is like fake news that Trump goes on about. So fabrication is where you make the data up. So you just sit in a room and fill in on your spreadsheet the data and you make it up. Or maybe you recruit 5 patients, but you say you recruited 100 patients. So that's data fabrication. And falsification is where you just change it a little bit to make it look better. So for example, if you think that the laryngeal mask worked 80% of the time, you change the data so it worked 99% of the time. So that's falsification. So fabrication is making it up. And falsification is where you change things. So a lot of people do this. It's incredible. And we're finding out a lot of people. And if you are caught fabricating or falsifying your data, your hospital is going to sack you. The police are going to come knocking on your door, and your regulatory authorities will strike you off the register so you can't practice as a doctor. So in the journal, when I find this, I have to write to the people, and I have to write to their hospital, their organization, and to their country's registration. And this happens all the time. So people try to get a paper in a journal. They want to be famous or they want to get a promotion, so they make their studies up. So I'm going to teach you about how to read it and how to work out whether you think somebody has fabricated their data. Because sometimes you read a study and you think, wow, this is amazing, but is it true? Did they really do this study? And when you do a randomized controlled trial, you're doing a random selection of patients from your entire patient group. And the random selection of patients will have random weight and height and age and a random number of men and women. And it's very, very hard to make that data up because nature is random, and as humans, we can't imitate nature. So we can't make up random data. Even the best supercomputer that NASA has in the world can't make up random data. So this is the top 20 of the biggest fraudsters who are doctors, who have had papers retracted. And you can see out of the top 20, 4 of them are anesthetists or anesthesiologists. So the top 20 worst in the world, and 4 of them are anesthesiologists. So the question is, are anesthesiologists bigger fraudsters than anyone else? Or do we just get caught more often? So number 1, number 2, number 10, and number 20 were all anesthesiologists. So you may have heard of these people. There's one, Scott Rubin, anesthesiologist. He served 6 months in prison, a fine of $360,000, having pleaded guilty to data fabrication. Here's another one, Joachim Bolt, who's talked at meetings all around the world. And this is the number 1 person in the world, Fuji. So how do you find out what fraudsters are like? So unfortunately, most fraudsters are men. They're not women. Men are the most likely to commit fraud, whether they're students, postdoctorates, faculty, consultants, or professors. It seems to be a thing that men are prepared to do, but women are not prepared to do. So here's this man, here's another one, here's another one. So Scott Rubin was an American anesthesiologist, professor in Boston, went to prison. He published 21 trials on paracoxib, COX-2 inhibitors, which you probably read about, and you might use COX-2 inhibitors as a result, but they were all fraudulent. He made them up. He fabricated all his data, and he went to prison. Joachim Bolt used to come and talk at meetings around the world on colloids, starches, and a lot of the guidelines have Bolt's papers on starches in them. He published 102 articles on starches and colloids and was responsible for all the guidelines about starches and colloids. 96 out of his 102 papers were fabricated. So he worked in his office and he filled in his spreadsheets and he printed off an ethics committee application and he made it up. He got a stamp from a shop. He stamped his own letters. Dear Professor Bolt, we're delighted to give you ethics approval for your study. He printed it out and he put it in his drawer. So when we discovered it, the police raided his office in his hospital. They found all these forms that he had printed out on his own printer in his own drawer from the ethics committee. So he lost his job as professor of anesthesiology in Germany, and he went to prison for 2 years. He's no longer practicing as a doctor, not surprisingly. Don Poldermans was a cardiologist from Holland. He wrote the European Society of Cardiology guidelines based on all his work in beta blockers. So a lot of the guidelines using beta blockers, he made all his stuff up. He was a fraud. He was sacked from Erasmus Medical Center in Rotterdam in 2012, and he went to prison. So when we look for a fraudulent paper, we look at the data, and we look at the data that makes it very, 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 very unlikely that it happened by chance. So if something happens by chance, there's a likelihood of it happening. So this was Fuji, and the picture is actually a little bit difficult to see. He actually wrote into our journal and said, this is not my picture. This is a picture of a surgeon called Fuji from Japan. But then we found out he was lying about that, and that is his picture as well. And this was the man that discovered him. He wrote a letter in to the journal and said, we read with interest the recent article of Fuji from Japan. We notice with amazement that the results are incredibly nice. So it's a very interesting word to write in a letter, isn't it? The results are incredibly nice. And we realized the side effects were identical in all groups. So we published an article looking at all Fuji's 168 randomized controlled trials. So in 20 years, he did 168 trials. That's 8 to 10 trials a year. That's one randomized controlled trial every month. That's incredible. It takes me about 2 or 3 years to do one trial, and he did 168 trials, 13,000 patients, 26 dogs, and 1 study in guinea pigs. So he was enrolling 600 patients a year, and mostly about granisetron, ondansetron, and post-operative nausea and vomiting. And this is the data in his study. So if you look at that, that was a table 1 in a lot of his publications looked like that. So what can you see about that data? It's beautiful, isn't it? 6 women, 9 men in one group. The next group, 6 women and 9 men. The age, 47 plus 7, 47 plus 7, 48 plus 7. The weight, 56 plus 6, 57 plus 6, 56 plus 7. It's amazing, isn't it? How could he do a study where the data are so close together? Is it possible to get all those patients and them to be so similar? Of course it's not possible. So he was making it up. He made the whole thing up. So all these data, if you look at this one, this is another one. Granisetron paper, 100 patients, always the same, 20, 20, 20, 20. 5 groups with 20 patients in. The age, 46, 47, 45, 47. The height, 150. Are there so many people that are so identical? Are we using identical twins, 100 twins? No. So he made it up. And he had 192 papers published like this in every journal, anesthesia and analgesia, anesthesiology, BJA. That he made them all up. And as journals, we published all this, and it's absolute rubbish. It's clear when you look at it that it's rubbish. So this is a normal distribution curve that you see in your medical school textbooks. That's a normal standard distribution curve. This is his distribution curve. So what can you see? All the data are right around the mean. So because he was making it up, he was putting all the data right around the mean. There was no spread. That's impossible. That doesn't happen in life. This is life. This is made up. So you can spot that if you look at the data. There's no way everybody had the same height or the same weight or the same people. So the chance of the weight in Fuji's paper being the same was times 10 to the 33. Now that is a very small number. That is 1 in 1 decillion. So the chance that Fuji's data was real is the chance of finding 1 atom from all the human bodies of Earth and finding the right atom. 1 in 1 decillion. So there's no way he did his trials. So we published this paper showing that it was impossible for to have done his trials to the 1 in 1 decillion chance. And in the end, all his papers were found to be fabricated. He lost his job. He went to prison. He's now working in a professor of, back working as a professor of anesthesiology, but in Fukushima University. So you may have heard of that university. That's where the nuclear explosion was. So that's the only place he could get a job after his fraudulent. And this was in Nature, and we published it. And then here is another, also from Japan, unfortunately. This is an author called Sato, and he copied all the graphs. He had the same graphs in lots and lots of different articles, in lots and lots of different journals, and he also made his data up. He was investigated by the Japanese Society of Anesthesiologists, and when they asked him what had happened, he said he made it all up, and they sacked him from the Japanese Society of Anesthesiologists, and they said he could never be a member of the society again. Luckily, it's not just anesthesiologists. This was Dr. Sato. He was a bone doctor, and he had 42 papers that have been retracted from fraudulent behavior. He was also very productive, 33 randomized control trials. The chance of his data being true was 1 times 10 to the minus 82. So that's even more unlikely than Fuji, which was times 10 to the minus 33. So he was looking at hip fractures. And unfortunately, once he was sacked by his institution, he committed suicide, because in Japan also, if you're accused of something and you're found guilty, then it's obviously a big humiliation. So he unfortunately committed suicide. So this has very big human consequences to people. So we know how to capture data that's false. We have a program on our computer, so when you send us your article, we put it through the machine, through the computer, and we know whether the data are real or not, to the 10 to the whatever it is. So we can work it out. And we've published the code to do this on one of our articles. So you can also work it out. So you can go to any paper, if you type the code into your laptop or your iPad, and you can look at the data and work out the chance that it was real. So the paper that we described it on, this is the altmetric score, and you can see this has been in 72 different newspapers, and it's our #1 paper, so it's an altmetric score of 955. And this is a very, very important paper. So this was it reported in The Guardian, The Scientist, and all sorts of different newspapers. And it basically explains and looks at every single journal, anesthesia and analgesia, BJA, Canadian Journal, JAMA, and the New England Journal of Medicine. And we looked at everything they'd published over 10 years to see how many were fraudulent. So these are all the different things that can happen with the data. And you can see that only the bottom one is data fabrication. So you can make a mistake with your data as well. You can type it in wrong, or you can calculate it wrong. So there's all sorts of different reasons. And what we found was these were the trials that were fraudulent. So there were 67 in total. 8 from the New England Journal of Medicine, 11 from JAMA, 5 from EJA, 9 from Canadian Journal, and 8 from our own journal. So these were all the suspicious ones over the last 10 years. And we wrote to all these authors, and we asked them to send us their original data. What we found, it wasn't just anaesthetists, it was everyone else. So the New England Journal published papers, and some of them were wrong. And the JAMA published papers, and some of them were wrong. So there was no difference between anaesthetists and non-anaesthetists. So the point is, you have to be a little bit skeptical and don't believe everything you see, because a lot of what you do see in journals is correct, it's right, but some of it, people make it up. So you have to be a little bit skeptical, and when you see something that looks too good to be true, you have to look at the data and think, maybe it is too good to be true. And we will always screen all our articles so that we don't publish these too good to be true articles. And the New England Journal of Medicine last month, they went over all the ones that we said about, and they found of the 11 trials, 5 were errors, and 3 have been corrected. So they published all the corrections based on this method. And the one trial that they found was incorrect was this one, was the Predimed trial, which looked at the Mediterranean diet, looking at olive oil and a diet based in the Mediterranean, and they found the study was wrong. So they said it was a randomized control trial, but it wasn't randomized. They randomized each town at a time, or each village, or each city at a time. So they randomized one patient in a town, and they gave everyone else in the town the same diet. So it wasn't, they only randomized about 40 or 50 towns, not 5,000 or 6,000 people. So it wasn't a randomized control trial, and so the data wasn't consistent. So the New England Journal has retracted this paper on the Mediterranean diet, and they have 100 other papers about this Mediterranean diet that's all going to be retracted as well. So this is a big, big news story that all the papers on the Mediterranean diet are now under suspicion of being retracted. So the Mediterranean diet was hugely impactful, and the science fell apart. So everybody heard about the Mediterranean diet being wonderful, but the science was wrong. So if we get a paper that we think is fraudulent, we will contact the authors and ask them to explain it, and then if they can't explain it, then we will contact their institution and ask them to explain it. So what does this all mean? There are lots, unfortunately, of trials in the literature that are fake. There's trials about oxygen that are coming up that you're going to find out about that are fake. There are lots of things that people have done that are bad. There are bad people everywhere. There are bad people trying to take your credit card. There are bad people trying to steal your car or trying to break into your house. And there are bad doctors who don't do the studies, make the data up. So in anesthesia, we will find them and we will look for them. And the New England Journal of Medicine and the Lancet also use the same screening tool, and so do the Cochrane database. So eventually, all this will be cleared up, and the guidelines that were wrong will be redone. So the guidelines on starch, on post-operative nausea and vomiting, they will be done without the fraudulent data. So you need to be just a little bit careful about what you read, and be very careful that you never do anything that's fraudulent, because you'll get caught. So you might not have got caught 10 years ago, but now you'll get caught. Check what you're submitting very carefully. It's always good to have a statistician check your data and make sure it's all been done properly. And unfortunately, what this means is people lose trust in us as doctors, because they hear this in the newspaper that we make studies up, and that we've had research grants and that we made it up. So we have to rebuild trust in the medical profession and make sure that patients trust us. And unfortunately, there's a lot of anaesthetists that have been doing this. So we have to particularly build trust in anesthesia research. And unfortunately, in every work of life, people behave badly. So it's not just us as doctors, it's everybody. Thank you very much for your attention.
Thank you, excellent talk. Now the topic is open to the audience. Any question, query from the audience, please.
I'm Dr. Thomas Koshi from Sri Chitratirtha Institute, Kerala, Trivandrum. So very enlightening talk with data. So what does the future hold for? Are the journals really going to take care of this fraud publication from now on?
So the future is we now screen it. So 10 years ago, we didn't have a tool, so we didn't know. And we used to publish these fraudulent articles. Now we can screen it and we can see. So now we won't publish them. That's in anesthesia, the New England Journal of Medicine and the Lancet. The other journals haven't yet done it. So we can find out now before we publish it. And then we also have to set the record right, which is going backwards to find the ones that have already been published and retracting them. So people write into us and we look at them, and if we think they might be fraudulent, we speak to the authors and to try and find out. So it's going backwards to clear the ones that have already been done, and going forwards to make sure we don't have any in the future. So it's getting harder and harder if you're an author to submit fraudulent data. The only thing is we can make it as hard as we can. It's like putting a gate and some dogs outside your house to prevent it being broken into. You make it harder, people will always get around it. You know, they can always break into your house with the best alarm system.
At what stage you detect it? From the editorial office, or you will send it to the reviewers, then come back at
submission. So when we get a paper that's submitted, the first thing we do is put it through plagiarism software to make sure it hasn't been plagiarized, copied. The second thing we do is put it through the data software to look at the chance of to look at the standard deviation and the population. So we don't go forward to the review process until it's past the plagiarism and the data software. Same with the New England Journal, same with the Lancet, same with Cochrane.
Thank you. Thank you very much.
That's all right.
Sir, I just wanted to ask that you were saying that the raw data is asked for. So as a researcher, I would like to know, for how long should I get my data stored there in place so that I can be...
10 years.
10 years.
So under the Committee of Publication of Ethics, any author who submits a study should keep their data available for 10 years after the study was submitted for publication. And if we ask you for your data and you don't have it, then we'll retract your paper.
Right.
And that's with any journal. So you have to have your data for 10 years. So when people are fraudulent, I ask them for the data. Do you know what they say? I've lost my laptop. The laptop fell in the toilet and it doesn't work. My children poured my tea on my laptop and it doesn't work. My office burnt down and I can't find the data. We changed offices and we threw it away. Those are the excuses that we hear. So it's the same one when you go to school. Where's your homework? I lost it. My brother threw it in the dustbin. So it's always the same excuses, but the answer is 10 years.
So you need to have those Excel sheets or the performers or everything kept for 10 years.
Correct. And then you will never have any problems. So if the data's real, it's fine.
Thank you.
So if you're honest, you keep your data. If you're not honest, you lose it.
Sheila Maitra from Mumbai, Tata Memorial Hospital. Excellent presentation. Just looking at this, I was just wondering, like, especially with trials that are big and impact practice, I mean, though you have stringent methods to catch, statistical methods, people can still fudge data intelligently, and sort of not do the studies or, fabricate some data, modify some parts. So wouldn't it be a good idea, especially with big trials that impact clinical practice, to actually ask upfront for the database? Because, practice changes and then we go back and say, oh, this data was fraudulent, and that's kind of, quite
So the New
upsetting.
England Journal always asks for the data. So when you submit your manuscript, you have to submit the data, and their statisticians will do the calculations again. So it drives you mad. You spend 6 months or 1 year looking at your data, and then the New England Journal do the same thing for you, because they don't believe anything. So that's a good thing. And we also ask everyone to have their data. We don't repeat the calculations for all the data unless we think it's something unusual. So we will always look at the data. But the only thing we can catch is fabrication, when you make it up. We can't catch it when people change a few things to make it look better. So when people polish it a little bit. It's impossible to catch that at the moment. There's not the software to do that. So we rely on institutions to collect data and to audit data and to look at that. So we can't stop people making it look more beautiful. We can just stop them making it up.
So institutional data monitoring and safety committees should look at that.
Yeah, and that's the problem. We can't stop that. Because you could just change a little bit to make it look better, and we can't stop
But
that.
anesthesia also asks for the database, your
Yes,
journal, or for all the
we
studies?
ask for the original data if we have any suspicion. So we quite often, when you email us a study and we like it, we'll ask you to just email us the spreadsheet.
Okay.
It's confidential. We'll then check it and send it back to you.
So Dr. Andrew.
Any more?
Yeah, can I? So Dr. Andrew, I really appreciate this presentation that you have done. And it's a little scary.
It's very scary.
Considering the fact that today we are all talking about evidence-based medicine, and the evidence is actually coming from all the studies that we have been accumulating.
Yeah.
And especially when you talk about something basic, like the starches and the colloids.
It's very scary. And antiemetics and COX-2 inhibitors, oxygen. You're going to blow your mind next year in 2019 when you hear about a lot of trials of oxygen that were fabricated. So it's very scary. And evidence-based medicine, the evidence in evidence-based medicine has to be right before you base it. So what our job is to tell you about it and then to redo the guidelines and the meta-analyses and so on and so forth. But it takes time. It's very scary. And it's not any one country. So it's not saying that people in one country are bad and not in the other country. We've had people from the UK, America, Israel, India, Egypt, Turkey, Japan. I've told you about some of them. It's from all over the world. There are badly behaved people everywhere, unfortunately. It's not one country. We're not picking on any, country. It's just people. Most people are very good, but some people are bad, unfortunately.
Unfortunately.
Excuse me, I'm Dr. D.K. Singh from Varanasi. I'm reading the lines written by Mercia Angele, a physician and long-time editor-in-chief of New England Journal, and she is writing that it is simply no longer possible to believe much on the clinical research that is published, or to rely on the judgment of trusted physician or authoritative medical guidelines. This she has written after 10 years of her experience as editor.
Correct.
So what to believe? What is your comment?
So what do you believe? It's very difficult. That's why I said you have to be skeptical. And some of what is in the guidelines and evidence-based medicine is unfortunately not true. And some of the things we hear, that Donald Trump wants us to hear is not true. In our elections at home, what comes on Facebook and what comes in the news is not true. So part of us is to be skeptical and to look at what is true and what is not true. So that's why the New England Journal has gone through everything for the last 10 years to take out what's not true and to screen it for the future, will lose their job. But the institution, it's the embarrassment of having somebody in their department, in their institution who's been sacked. Why didn't they know? Why didn't they know what was going on with their employee? So if you're the head of department, you need to know what's going on with your employees. So in the US now, some institutions, they will not allow their researchers to submit a paper until they've checked it. So for example, MIT, Massachusetts, Harvard, none of their employees are allowed to submit a paper to a journal until the head at MIT at Harvard has checked it and said, yes, this is fine. Because they never want to be accused of having one of their professors or postgrads or whoever it is be accused of fabrication. So they check everything in the institution. So it may be that as, professor, head of the institution, we have to check everything. But of course people are scared. They worry that people will copy their work and so on and so forth. But yeah, the institution is bad. But for the person, it's the end of the world.
So this is the next one. Yeah. It will be the next one.
So I'm in the career almost in the tail end of my sixth decade of my career. This particular irregularity has surfaced and galloping mainly for giving a lot credit for the publications by the employer. It started mainly from US, where there is a dictum that publish or get perished.
Publish or perish.
I have a feeling that whether we go for a negative area, that for publication, no credit should be given for the promotions. It should not be point for evaluation. Because what is happening, that in the human system, the essential part of the human system or the world is the trust. And today we are losing the trust on each other.
I do agree with Dr. Dasgupta, sir, because a lot of pressure from the administrator, different councils for career promotion has led the doctors in developing countries for fake research publications. You have to accept it.
So yes, if the university wants to give you a professorship because you do your publication or a pay rise or something like that, that makes people want to do it so much that they're prepared to perhaps do something wrong. The more money you have on offer, the more, fame and fortune, that the more people will do something bad because it's very tempting.
Yeah, definitely. I agree with you. But there should be the policies needs to be changed.
Yeah.
People doing a lot of clinical works, they assemble they collect their data, try to publish, but a pure research is a different aspect. That should be advocated in two different ways at two different levels.
But without research, medicine doesn't move forward. Penicillin was discovered because of a case report in a journal. All the things that we do relies on people to do the studies. So we can't stop people doing studies, otherwise there won't be antibiotics for me when I get sick, because I'll be resistant to all the antibiotics. We have to do research.
Sir, this is Dr. Neha from AIIMS Bhubaneswar. I do agree with sir and there also. But the thing is, sir, can't we make some policies that clinical work should get the equal weightage? Like you see the weight of the CV, it used to come. How many publications you are having? 100. Then they will not give weightage to the person who is having 25. But I am sure all of us must be aware of some people around us who are very good at clinical work, but not having good publication. So it's all depend on one's interest that I'm doing my clinical work, I'm very at par at doing clinical thing, but I'm not that versed or well oriented for the research thing. So clinical work should get the equal weightage.
Yes, but also not just that, also education, teaching, how good you are teaching your colleagues or your postgraduates, how good you are at your clinical work, how good you are at helping your colleagues, all those things are important. And research is just one part of it.
I just have one question on you said the spreadsheets that you ask for and the data that is sent.
Yeah.
So if this article doesn't get published,
yeah.
So are there concerns, your idea would go out, the data would it be like, are there concerns for researchers sending out their data to journals like this?
But you sent me your paper, so if I wanted to copy it, I can copy it.
Right.
So you have to trust that the person you send it to in the journal is not going to copy it. So we only send it to our statistician, and then we get sent so much that is confidential.
So it's all confidential.
You have to trust us. It's like you trust your bank with your card, or you just have to say that the people in the journal, we're not going to copy your work. If we do, I lose my job.
Okay. Thank you, Dr. Andrew.
Thank you. So just a minute, last question. Suppose that we are sending the data to the journal and it is not getting published, are there any policies that they are going to remove it from the database?
Yes, so we just delete it. So whenever we reject your paper, we don't keep your paper and your data and so on and so forth. We delete it all.
Okay. Thank you, sir.
Thank you. Thank you very much.
Thank you, Doctor.
I request Dr. Vasundhara Atre, ma'am, please felicitate Dr. Andrew Klein with the plant. Please come on.
research. Oh, thank you very much. Thank you very much.
You want to come in the front?
Oh.
So we pass on to the next session. The next speaker is Dr. Ravi Shankar Rao Bikadi. He will be discussing on the topic anesthesia and cancer. Can we make a difference? He is presently affiliated to Royal Marsden NH Foundation Trust. His achievements are Association of Anesthesiologists Council member, research of anemia management, hemorrhage management, exercise testings. He has got awards in that area. He has got a lot of publications. He has presented a lot of papers in international seminar on blood management and anesthesia for major surgery since last 13 years. And he will be talking and updating us on anesthesia for cancer surgery.
Thank you very much for the warm welcome. On the note of skepticism, what I'm going to say for the next 25 minutes is it'll all be very skeptical for you. So these are my disclosures. I'm a council member of Association of Anesthetists as well. This is my department. This is Royal Marsden Hospital, one of the oldest cancer hospital in the world. So, and I think a lot of you must have heard of it. Thank you, ISACON Agra. Fantastic opening ceremony yesterday. I like the theme, expanding horizons beyond the operating room. As you can see, the president and also organizers, everybody leading the way outside the operating theater. This me. I think a lot of people are asking me, nice to see some old friends. I'm originally from Manipal and studied in Bangalore. Then did my anesthetics, one of the best anesthetic department in the country, Cme Hospital. Then I went for a year and a half in Manipal. I think it's, I say every postgraduate, I tell you one thing, you must spend a year in an institution after your post-graduation. So just to learn the tricks of the trade, and also I'm honored to be a colleague of late Professor Tota and also Dr. Ram Kumar. Then I moved to St. George's Hospital. It is always nice to be in a hospital where everything is under one roof. Any specialty is in one place. This is one of the unique hospitals in the UK where any help you require from any department is there in one building. And then I went to Royal Marsden Hospital. It's not just the Marsden, it's famous for cancer care. It's the Institute of Cancer Research, where all the groundbreaking research on cancer and especially the lab research happens. And then I became a council member a couple of years ago, and some of our colleagues are outside, you can meet them. Right, I'm not going to tell you how to anesthetize a cancer patient. What I'm going to tell you is what has been going on in the last 10 or 12 years or so, whether what we do can make any difference to, especially in the cancer patients. Okay, I'm going to touch base on what's been the pathophysiology and also some of the recent lab research, what's going on, and also the current hot topic at the moment, intravenous versus inhalation anesthetic, and also what is the future for us, especially in our lifetime in the next 10, 20 years. So Andy's take-home message, be skeptical. Yes. Does anesthesia make a difference? I can probably say yes. I'll also probably say no. But I think the probably most common answer will be maybe. That's where I'll touch base on. Right. Why we should worry about cancer? It is a global problem, global hot topic at the moment. And it doesn't matter which part of the world you are in, okay? It's on the increase. I'm not saying that there's an epidemic of cancer, but it has been increasingly, there is a fantastic diagnostic kit, diagnosis early, and also we are all living longer. So more and more elderly people are presenting to us with cancer. And also, it's going to, the huge increase in the next 10 to 12 years is predicted. Of course, where the surgery operation comes into here, for example, majority of the cancer operation is a curative operation. 45 million cancer operations by 2030. So that means almost all anesthetists, either a day-to-day or at least a weekly, you will be looking after a cancer patient. Doesn't matter what specialty of anesthetics you are in. Of course, but it's not just one anesthetics, you'll be maybe giving multiple anesthetics to these cancer patients. As I showed you, this graph clearly says it's not just it's a world problem. I'll also look at some of the developing countries, it's a huge increase in predicted cancer diagnosis and cancer treatment. Right, cancer metastasis. How do the cancer spread? So all patients with the cancer have circulating tumor cells. This has been going around, okay? And then also, if we start handling the tumor during the operation, it can make it, the circulating tumor cells go up. As one of my friends said, the surgery is the #1 reason for circulating tumor cells when the handling of the tumor. And it's Jonathan Hiller's work, he was one of our fellow. And also, it's the way it is, it's a mechanism, it's just released from the cancer cells, then various aspects of surgical, be it the surgical technique or be it the interventions you do, the varying degrees of spread of cancer cells. And also, the volume status of the patient during surgery also may play a part in it as well. We all know that any major surgery is an inflammatory process, okay, which causes havoc in the immune system in the patient, especially sometimes after major surgery, patients don't do well at all because they are so immunocompromised, be it the surgery or be it the associated cancer treatment. So we know that if there is a difference between the success of the cancer treatment depending whether it's immunodeficient or immunocompetent. So these are all animal work. So the hypothesis, surgery, operation releases cancer cells to circulation, and stress response can modify immune activity. So that means we are all part of the game here. Anesthesia and surgery can simultaneously directly affect cancer cells or change our immune system. I'm going to just touch base on a few of the anesthetic aspects to get the clear thoughts of some of them, which one does affect and which one doesn't affect. Right, this is one of the original work which says is halothane, an isoflurane cone, has effect on pulmonary metastasis. It's not just the anesthetic agents, and also even with the large doses of fentanyl. So they showed, animal studies showed that there is an effect. So that more number of tumor cells if you have exposed to inhalation anesthetics or even a large doses of fentanyl. It's not just anesthetic, the general anesthetic. Is there any problem with the regional anesthetic technique? This is the original work from the group in Greece, and also it's in Ireland in Donald Buggy's paper. In the breast cancer surgery, they started doing a paravertebral block and then saying that can it cause. So it's an observational trial looking at the patients, a small number of patients, 79 patients and 50 patients so over a period of 36 months. And they showed us big differences. So there is, of course, there is a difference here. Here we go. What do we do, guys? And of course, Donald is doing a further research on it. And then started people noticing, okay, fine, paravertebral block. Now what about epidural? If you give an epidural for esophageal surgery, does it make difference? Again, this Jonathan Hiller's a small group of patients. He published in our own data showing that there is a difference. If you follow them up, there is a difference in recurrence, cancer recurrence. That led to, so what is in research world, what do we do next? We do a randomized trial next. Of course, Jonathan showed that if you give a neuroaxial blockade and it reduces the lymphatic flow, okay, and that means less circulating tumor cells, probably regional anesthesia is good for you, okay, reduction in the lymph flow. This Paul Miles group did a randomized trial on it, looking at general anesthesia with or without epidural for a major cavity surgery, open abdominal surgery in cancer. So they showed a long-term follow-up. Actually, it does not show any difference at all, whether with or epidural. It tells you one thing. Regional anesthesia or a local anesthetic, there is no problem with the cancer. It is safe And also, we don't know whether it's a huge advantage over it, but it is safe to do so. So one thing we can say, regional anesthesia is good for in cancer patients. What about non-steroidals? We heard about from COX-2 trials withdrawn. Probably single dose non-steroidals is not a problem because of the anti-inflammatory properties of these non-steroidal agents. What about patients on long-term non-steroidals? Okay, that's where the problem comes. The if you do a long duration of non-steroidals, I'll come to that in a bit later on, it can alter the immune system, and also it can alter the cell metabolism in a way that tumor cells survive longer. So probably long-term non-steroidals not good, but as an anesthetist, perioperative non-steroidals is, if the patient can tolerate, is not a bad thing at all. What about beta blockers? Yes, if you believe in it, if you give it to the patient on it, probably it's a good idea because we know that beta blockers reduces the stress on the heart. Apart from that, there is no direct effect on the cancer. So what happened? Slides. Technical error is here. Okay. Okay, thank you. Right. What about the other anesthetic agents, or the main anesthetic agents we use in day-to-day life? This needs a bit of an explanation. So we all know about, if there is a hypoperfusion, there is an organ ischemia, and people with the cardiac anesthesia know about it very well. And then when there is a hypoperfusion, that means cell goes hypoxic, and then we improve the perfusion, reperfusion, what we call, that probably is more damage to the cells due to various mechanisms. That means one of the main, when you have hypoperfusion, there is hypoxia to the cell. Then human body is amazing, human cells, they adapt, and there are various things released in the cell to protect reperfusion injury. Whereas in cancer, amazingly, the tumor cells, although the other cells trying to adapt, the tumor cells, they prevent all those adaptations, and they survive longer. That can cause metastasis. So these are some of the original works from in the last few years, showing that if you give isoflurane, it decreases myocardial infarction in rabbits and probably upregulate the hypoxia-inducible factor, which is one of the adaptability when there is a tissue hypoxia. Same thing in the mammals as well, saying that isoflurane improves the reperfusion injury. That's why the cardiac anesthetists prefer it. What about cancer? Again, saying that if we give isoflurane for a longer exposure, that in tumor cells, it's a different phenomenon. It worsens the damage, and the tumor cells survive. Because, so as explained here, these mechanisms can be sustained, which we have the high H1F alpha and beta. But if it's damaged, if you're exposed to something which reduces the downregulation of this, the cell survives longer, and there is metastasis chances. This is another original work from Hero Group, and showing the same mechanism of H1F and H1F2 and F alpha and HIF beta, showing that the cell goes through the mitochondrial damage and various releases, which makes the cell survive longer. Also, it's shown in ovarian cancers as well. It's published in 2015, saying that there is an effect on long-term survival of cancer cells if you're exposed to isoflurane. And because one of the mechanisms proposed is the mitosis of cells. And again, isoflurane increases angiopoietin and endothelial growth factor and endothelial cell formation, which in turn all favors metastasis. What about immunity? We all know that T helper cells play a major role in immunity. Of course, again, I emphasize surgery is an inflammatory process. It's a TH1 and TH2. One favors the tumor death and other favors the tumor escape. What happens here? We all know that now from the n number of animal studies saying that propofol favors TH1, that means cell death, whereas isoflurane, TH1 suppression, that means tumor survival. And of course, what about the cytotoxicity on the tumor by natural killer cells? Because you can see that control here at the top is a control. And if you expose them to isoflurane, look at the number of cells who survived. These are all exposed for a day of isoflurane. What about the existence? You say that there is a hint from the laboratory studies. How can we go into the clinical world? So is there any clinical data saying that propofol versus volatile, there is a difference? Choice of anesthetics make a difference. And the early hint from a few years ago saying that from the cancer surgery, there is a marginal difference. So we started looking at our own data by chance, actually, because Tim Wigmore and Sham Janji, two of my colleagues, and then we met a clever statistician, Kabir. So we shown our own data. It's mainly because Marsden is a total intravenous capital of anesthesia, capital of probably of the world, actually, in terms of cancer surgery. The majority of my colleagues, for some reason, we all love total intravenous anesthesia because majority of cases are either day surgery or we just got used to it. So no, this one, depending on the anesthetist, some of us practice, some of us 50-50. We have an electronic patient record and looked at the data. So all elective cases over a period of 3 years, 11,716. So if we filtered out some people came for multiple operations, small operations, less than 1 hour, we filtered all of them. So and then we look the matching group of 3,000 patients each. A patient either had a total intravenous anesthesia only or inhalation anesthetics. What did we find? The first thing to show is, look at the UK data, what's happening. In entire UK, only probably 15% practice TIVA only and majority inhalation. Whereas in Marsden, when you come to Marsden, probably now it's around 65-70% of us practice only total intravenous anesthesia. And we looked at what happened in terms of the metastasis and recurrence. There was a significant difference over a period of 3-4 years. And also we looked into adding the regional anesthesia. Regional anesthesia didn't show much difference, whereas patients who had TIVA or patients who had a volatile, there was a significant difference in recurrence and survival. Here are the numbers and the ratio, and then this is the statistician looked into the data. So this is what hypothesis. So general anesthetic drug used during cancer surgery impacts the physiology and the survival of the cancer cells and also metastasis. So you can say that this is all observational data. So what's the next step? What do we do here? Okay, so there are hints in the lab, and there are hints in the animal studies, and there are observational data showing that local anesthetic is safe, and also probably volatile is not so good for cancer surgery. There are two ways of looking at it. Either you say, hang on a minute, guys, either do a big randomized trial, you know that how difficult it is to do a big randomized trial, or go back to the